Right, I think we're just on 12 o'clock, so hopefully we've got everybody in the session. Welcome everybody. This is the fourth of our webinar series, Living with Multiple Chronic Conditions. This is about health inequalities, deprivation, gender, age, disabilities and ethnicity, which is a vast topic. And I'm very delighted that we've got two excellent speakers to help us through those. I'm Jane Skinner. I'm a retired cardiologist with a major interest in prevention and now working with Health Innovation North East North Cumbria. All of these aspects are very timely and appropriate. It's an important component is looking at health inequalities. And for those of you, some of you may have seen on TV this morning even that the increased levels of obesity in our disadvantaged populations. Next slide. A few housekeeping things. Please keep your microphones and videos turned off. If you need to take a break, feel free to do so. Drop out, drop back in again. We'll join you again. The event is being recorded and will be shared afterwards. So if you want the slides, if you want the event, it is being shared. And we'll come by email to you. If you have any questions, then please can you use the chat facility. We may have time to address some of those verbally, but if not, then our speakers very kindly agreed to try and deal with them through the chat. And if for any reason you've got any problems at all during the recording or with accessing or anything at all, then Sarah works in our comms team. And she's been very instrumental in setting up this webinar, making sure it all runs smoothly. Next slide. We're a Health Innovation Network. This is on behalf of Health Innovation North East North Cumbria and Yorkshire and Humber, who are working together as part of the wider network of health innovations. Next slide, please. We will move on to our speakers in a moment. I do just want to share with you, though, before we do that, that we really value your feedback. And this is the last webinar. We will be circulating a survey following the meeting, and I'd really encourage you to complete it. It is not just a tick box exercise. It very much informs what we do in the future, plans for future events and so on and so forth. So we really, really value your feedback. So please do that. And in recognition of the value of that, there is going to be a £25 Amazon voucher for one person who responds to the survey as a random selection. So there'll be a due date to complete the survey by. So do please try and do that for us. We really appreciate it. We'll move straight on then, and I'm delighted to be able to once again be able to introduce Dr. Ronnie Katab. He's a specialty consultant pharmacist in cardiology and cardiovascular clinical research with Leeds Teaching Hospitals NHS Trust. He has a national and international reputation and works on both of those. His biography is quite vast. I won't try and read it all out. You can see some of those that are coming up, NICE, ESC, so on and so forth. So straight over to you, Ronnie.
Thank you so much, Jen. Thanks everybody for attending. This is last, I'm just about to share my slides. This is the last session of our series, Living with Multiple Chronic Condition. So this is webinar 4. And in this webinar, we want to talk about health inequalities. And when we discussed health inequalities previously, if you remember, we focused more on the cardiovascular, renal, metabolic conditions. So my slides will be slightly focused on the cardiovascular, renal, metabolic element of health inequalities. And that's the objective of this session, to give you why health inequality is important and why health equity is important when managing chronic conditions, with a specific focus on the cardio-renal metabolic area. Health inequalities are avoidable. There are unfair differences in health outcomes between groups due to social, economic, or environmental factors. These are the different domains of health inequalities. Could be seen in protected characteristics such as disability, age, gender, socioeconomic deprived element as well as we have the geographic areas, the inclusion, of course, and vulnerable groups. So we're going to be touching on that and just exploring some of this data. I'm sure this data can be found, and probably Helena might be also referring to it, but this is a reflection of some health inequalities. If you look at the deprivation impact on life expectancy, you see that most deprived areas have lowest life expectancy and healthy life expectancy. And the difference is vast. There's nearly around 10 years difference. So if you're living in most deprived areas, you'll probably be living to an age of around 73, whereas if you live in least deprived areas, you will be living to an age of 83. So there's about a 10 years difference. And if you look at the healthy life element, there is also a gap. So it's not just about living longer, it's about what kind of good, healthy life expectancy you have. And you can see that there is a gap of nearly about almost 20 years difference in healthy life expectancy. And of course, there's geographical differences as well. Now, this is not good because we need to be fair and understand the reasons driving that. Same thing, for example, if we were looking at the distribution of illnesses and how many illnesses people are contracting depending on where they live, you see that areas which are least deprived, people contract less multiple conditions or multimorbidity compared to those who are in most deprived areas. Again, that indicates challenges and impact for the health system, for the society as a whole, for people, for families. If we expand that by condition, you can see that if you look at ethnicity, for example, each ethnicity have different challenges in terms of the conditions that they battle with. The question is, what can we do to support people equally, or maybe in equity rather than equally, and explain the difference later on. So these kind of some of the distribution, different illnesses experienced by different ethnicities, and the prevalence of these conditions that lead to morbidity. Talked about that already. Of course, learning disability is another area, and respiratory disease, which we did not cover in our CVRM review, and respiratory diseases are the most or the biggest drivers of death in this population, and it requires us to understand why and how can we tackle that. Do they need more support? Do they need more scanning at a younger age, instead of bypassing or opportunities for intervention? Why do we need to tackle health inequalities? Because it's burdensome economically. The NHS spends 4.8 billion annually on avoidable hospitalization due to health inequalities. But there is also an indirect cost to society, which amounts to nearly 31 billion per year. And that's around productivity, people not being able to work, impact it has on being absent because of illness. There's also an ethical imperative here. People in deprived areas are dying 10 to 15 years earlier. We need to do something about that. And 40% of CVD deaths are preventable, and it seems to be linked to deprivation. So clearly, we have multiple reasons. And why the focus on CVRM chronic conditions? Generally, because chronic conditions, as we said in the first webinar, that it actually contributes to 80% of premature mortality. And CVRM is a large bulk of that, 80%, and that's why the focus on CVRM is the reason for it. I don't want to dwell into a lot of the causes, but there is socioeconomical factors, what people can and can't access, whether it affecting their lifestyle, how many hours they sleep, how many hours they work, what kind of food they eat, what kind of housing they live in. But there is also access barriers, GPs accessibility, healthcare system accessibility, rural areas, for example, and what can and they can't access. Where you've got more condensed areas, how do they access services? Do they have enough services? There's also structural inequalities, whether it's just language barriers, which is racial discrimination, digital exclusion as well, important. And there is also policy gaps that could contribute to these inequalities. So it shouldn't be seen as a personal or an individual problem. No, it is bigger than that. It isn't. It could be one or more of these factors. For example, geographic differences. Why is it that CVD mortality is higher in Northern England? Why is it, that there is higher prevalence of hypertension and CKD in Black African Caribbeans? Does that mean, are we doing enough to support them with that? Are we providing them as we supposed to? The deprived groups, do we do more screening, less screening in those areas? If we want to look at the stark disparities in specific conditions, if we look at, for example, cardiovascular disease, and I'll detail it more, you are more likely to die almost 2.5 times more if you're living in a deprived area from CVD disease. If you're looking at the diabetes territory, there is 60% higher chance of developing diabetes if you are in a deprived group. CKD seems to be more of a challenge in Black communities, where 3 to 5 times higher risk of CKD in that population. Obesity seems to be higher in deprived areas, with childhood obesity almost twice. So all these challenges are important, and we need to understand so that when we commit resource, we need to think about that. I've already talked about premature mortality in CVD, for example. There is also the ethnicity challenge and the geographical challenge that highlights. There are interventions, which I'll be just touching on some of them, that NHS England is trying to do in order to tackle that, whether it is public health campaigns in order to look at the root causes of these disparities, whether it's related to diet, smoking, or the core 20+5 that NHS in England has launched, and I'll detail that a little bit more. And there is better accessibility, such as having community pharmacies doing BP checks for better detection and management of blood pressure. And using my NHS England CVD prevention hat, this is the data that we have in the CVD Prevent. So if you notice in these kind of diagrams, it reflects what we've been talking about, higher rates of death from CVD in most deprived local areas. You've got premature death rates higher, declining, but there is differences between males and females. If we do a little bit more focus on CVD risk factors, you'll find, for example, that people aged 25 to 45 years old in the north of England are 47% more likely to die from heart disease compared to those in the south. So that's kind of specific population as well. It's not just overall, but specific population. Patients from the most deprived areas are least likely to have hypertension or cholesterol managed to target. That's something is modifiable. Why is it that people in the most deprived areas are not supported so that their blood pressure and cholesterol is well managed? You've got the Black and mixed ethnic groups across multiple risk factors seem to be less likely to be prescribed appropriate drug therapy. Why is that? Why we're not offering those drug therapies? And people in the younger age groups are less likely to be treated or targeted across multiple conditions. So we've got a lot of missed opportunities that means that when we're committing resources, we need to understand these disparities in order to shift resource and efforts to address the gaps. If we do even a deeper dive and we look at hypertension, for example, this is from the CVD Prevent data, and you will note that the trend here, that younger people are less likely than older people to have their blood pressure managed to target. And those people are the ones who are going to go on and develop multiple chronic conditions as they grow older. Only around 40% of hypertension patients, 40% of hypertension patients had not had a blood pressure check in the previous 12 months. So that's things we can do something about. And the question to ask, why is it happening? If we look at it more in deprivation and ethnicity, you will see that people with higher blood pressure are more likely to be admitted to hospital with stroke or heart attacks in the following 12 months. So we know that this is going to have an impact on the NHS, but also the health system, on the individuals, but also on the society. So we can explore this data using the CVD Prevent data nationally, but also locally, regionally, and even down to practice. And that's quite important data to understand. If you look at the trends in lipid management, we have similar challenges. So, for example, patients with CVD in the most deprived areas are more likely to be treated with lipid-lowering therapy, but they're less likely to have their cholesterol managed to target. Why is that? Is it because we fire and forget? Is it because we are not making the service as available to those people to support them to get to target? So that's another challenge, for example, we have. And that's an interesting deep dive that we did in the CVD Prevent data, looking at gender differences. And in this one, it shows that women with CVD seem to consistently be not treated with lipid-lowering therapies, which is shouldn't be the case. Why is it that we're not treating females with lipid-lowering therapies? And then if we go on to look at whether their targets are being optimized, i.e. they're supported to meet target, you'll see that consistently they're also less likely to have their cholesterol managed to target. And if we look at the CVD burden, that large number of those women with CVD don't seem to have a recent prescription for lipid-lowering therapy. There's a lot of disparities here that we need to understand the reasons behind it first, and then we need to do something about it in order to address it. So this is an example of why we need to do data collection, and we need to analyze the data so that we understand where seem to be the gaps and disparities that we have within our community on an ICB level, even on a place level, and even on a practice level. And CVD Prevent is one good set of data that can be used in order to appreciate those differences. So that's why we recommending that we apply the core 20 plus population concept, which I will detail later on, but there is a need to use the data to identify the gaps and the disparities and to invest to understand the reasons behind them and tackle them. Well, these just examples related to some of the risk factors, but if we look at, for example, heart failure, which we've covered in our webinars, you'll notice that there are also differences in heart failure prevalence in where deprived areas have much higher prevalence of heart failure compared to least deprived areas. Why? Why is that? And are we detecting early enough? Are we treating early enough? Are we managing the underlying causes early enough? Diabetes is also a challenge. For example, we said deprived areas are more likely to have type 2 diabetes. If certain ethnicities have higher prevalence of diabetes. If you look at complications of diabetes, seems to be higher in deprived areas where 2.5 times higher rates of amputations. There are some national initiatives such as the NHS Diabetes Prevention Program, which seem to have achieved about 50% reduction in diabetes risk with tailored intervention, and addressing barriers that also seem to prove examples of good interventions. CKD is another area where there's clear disparities. Advanced CKD is 4 times more likely to be common in deprived groups, and deprived patients are 50% less likely to receive pre-dialysis care. Why is that? registries or audits like the CKD audit, it helps identify and diagnose cases in high-risk groups, and it helps us to understand what can we do to address that. So, for example, the outreach mobile clinics in Birmingham and London was a very good example of how certain CKD detection and management was much better. Another thing which is quite interesting, and there's mixed literature on, is, for example, prescribing of the right medicines. So SGLT2 inhibitors prescribing, there is also disparity in prescribing SGLT2 inhibitors by ethnicity and deprivation, where some studies showed no statistical difference, others show some. So why is that? Why is it that certain areas, certain geographical areas, there is or more deprived areas seem to be less likely to be prescribed these medicines which have proven cardiovascular benefits? So this is another area that could be done by doing a bit of data analysis interrogation in your region or even in your practice to understand if there are any disparities and why and what the reason for these disparities, and therefore tackle them. We have covered in the past MASLD, and MASLD, which is the new name for the fatty liver disease, is also more prevalent in deprived areas. It's 3 times higher in deprived groups, and 70% of cases is in deprived areas are usually diagnosed late. And as we know, there's a huge correlation and association between MASLD and cardiovascular disease and mortality, and therefore, what are we doing to actually diagnose it earlier rather than late? Is 70% diagnosed late? Why is that? There are, again, like different initiatives, such as integrated liver screening and diabetes. So are we doing enough liver screening when we're managing people with diabetes? Because we know that MASLD is more prevalent in patients who have got obesity and got diabetes. Do we understand the barriers? Is it the lack of awareness? Is it the lack of access to specialist services? What are the reasons? Now, to just overall talk about the tackling of health inequality strategies, I'll talk about the core 20+5 framework, which targets deprived 20% and high-risk ethnic groups for CVD, diabetes, and CKD. And of course, we can touch on that. Community-led interventions, because we need to know why certain geographical areas or ethnicities seems to have challenges, such as we know some of the programs around delivering diabetes prevention programs, integrating within policy and thinking about health inequalities when policies are being developed. And of course, very important, as I've demonstrated early on from the CVD Prevent data, that data-driven equity audits are really important. It isn't enough to report the averages. It's important to do a deep dive to understand if there are any disparities and the need for equity. Obesity is another challenge. I've just listed it there. Obesity rates are 2 times higher in deprived areas. And among adults, 38% of adults in deprived areas are obese versus 22%. Ethnicity also makes a difference. And again, policies, for example, are an area. So I'm just going to touch quickly on the Core 20+5 initiative, which is by NHS England. And as you can see here, it's got different elements. So I'll break it down in terms of what it actually means, because you've got the core 20 that talks about that the most deprived 20% of the national population is the target. And the plus element, the target population, I'll detail it. The 5 are the key clinical areas of health inequalities that have been identified. Of course, not all of them are related to our CVRM, but the hypertension case finding is an area of focus. And of course, smoking cessation is another area which is relevant to all of them. So if we break it down, actually, the core 20, I've already said, is more about looking at deprivation index and targeting the 20% of the national population identified by the deprivation index. The plus, the population groups should be identified at a local level, because the distribution of those population within the population is differing. So ethnic minority communities, people with learning disabilities, people with multiple long-term conditions, and other groups that share protected characteristics. The fives is, as I've highlighted early on. And the idea is to actually identify the reasons where if there are any inequalities, and then work on equity. And equity is all about just not about just giving everybody the same resources. Actually everyone gets the same outcomes, so therefore resource distribution is according to need, and this is what we're after. We're looking after equity in the provisions that we're providing in order to bring everybody to the same outcomes. Everybody will have their own challenges, whether it is geographically, whether it is ethnically, whether it is deprivation related. The idea is to have equity in our investment and services in order to achieve the outcomes. So there are a lot of case studies, and it's beyond the scope of the talk to cover them. But for example, the NHS Diabetes Prevention Program did target deprived and ethnic minority groups, and it had a good effect. It impacted 50% reduction in diabetes risk with lifestyle interventions. And the lesson learned from this initiative was that equity requires an equal resource allocation to level the playing field. That investment saves later on the consequences of health inequality. And you've got the addressing of the structural barriers as well that you have. This is another element that highlighted by the King's Fund, looking at language access, digital inclusion, and workforce diversity as well. This is an interesting American approach, which not all of it is relevant to us to address. And this is from a paper which talks about how to enhance equity in the CVRM territory in specific. What is interesting is that some elements are actually similar to what we do. So, for example, there's a community level. So looking at the left there, so resources and policies need to support community efforts to address inequitable policies and also social determinants of health, such as housing, food, lifestyle changes, but also addressing built environmental factors. So this is all about policy, public health, and focusing on the risk factors. And of course, in America, insurance is a challenge, but probably here is probably access to health services. And then within the health system, it is important to
Ronnie,
improve.
Can I just?
Yes, sorry.
There's been a comment in the chat about the slides being behind what you're actually discussing. No, I'm not sure.
Oh, really? Sorry. I should be on the slide which says consideration for enhancing equity in CVRM. Are you seeing that, Jen?
Yeah, no, that's fine.
So I'm not sure yet. So the health system, surveillance of risk factors is important. So we shouldn't wait for actually the conditions to advance. It's important to have a surveillance in place for the right factors. Are they up to date? Empowering patients and self-management is important in order to address, to enhance equity. Decision support and empowering patients, delivery of the system, having multidisciplinary approaches to these systems is quite important in order to have more holistic. And that's why they create system for closed loop referrals to manage barriers, pharmacy equity and care, and clinical information systems, etc. So these are some of the elements that were raised. Now, if you look at the King's Fund kind of report, it talks about prioritizing, focusing, and investing. So, for example, if we want to address CVRM, then we need to prioritize CVRM in inequality strategies. So we need to say, what do we have in place in CVRM territory? I need to focus on the early detection and primary care. So it all talks about the NHS new thinking and shifting, the 3 shifts of the NHS, which is one of them shifting to prevention instead of just managing conditions. So we need to think early on, early detection, prevention, and investing in that. And that is interesting. I was in a talk recently about CVD prevention, an international one, and I like the phrase where it said CVD prevention is actually an investment in wealth. It's an investment in wealth. Investing in CVD prevention is investment in wealth. Because if you think about it, if you invest in CVD prevention, you are investing in, you're reducing the need for accessing later on secondary care and hospital admissions, and also you are reducing the social burden, economical burden, which actually a huge investment, which will lead to huge savings and cutting of costs later on. So it's important to see it as such. So when we invest in community-based lifestyle interventions or any other CVD prevention and early detection, we're actually investing wealth in here, because we're going to save future. That's to conclude. Health inequalities and chronic conditions are preventable, but persistent. We need to have targeted policies, which we already have, community partnership and multidisciplinary working. We need to have an equitable resource allocation, and we need to think about equitable health and outcomes, and it needs to become a priority within NHS funding, research and delivery. Thank you so much.
Thank you, Rani. That's great. We haven't got any questions in the chat. So I think what we'll do is, if people have them, then please add them to the chat as we go forward. But I'm going to introduce Helena Gregory. Is one of the strategic heads of medicines optimization for North East North Cumbria Integrated Care Board, and oversees patient safety analgesia in the North Cumbria area. She's got a vast experience in community pharmacy, general practice, education and development, and clinical quality, and is very passionate about the importance of getting services to patients and making sure that there are no inequalities, which is a real challenge. So I'll hand straight over to Helena to take us through.
Thank you so much, Jane, and thank you, Rani, for taking us through all of the policy and evidence behind it. And I think it's fairly overwhelming. It's fairly overwhelming for you guys as healthcare professionals who are sitting there in your clinic, and people are coming into you, and you get this, but you feel a discomfort or an overwhelm because our time is stretched, our resources are stretched, as Rani has suggested, and how do we support people practically with some of that when things are so difficult? So I'm going to go through hopefully a few practicalities today to look at how we can put that into practice. And looking back at some of the things, if you've been in some of our previous webinars, just a little bit about what we did. We will have a Slido session later on. If you didn't pick it up from the first one, don't worry, because it will come up again with the codes, and have a look through a few practical examples at the end of how living with health inequalities can affect your access to healthcare, exactly as Rani was talking about. But just to carry on from Rani, from the context level, and absolutely right, Rani, going to show a very similar chart to you in terms of how long you live, which is the top one, your life expectancy, and how long you live well, which is the bottom one. And that is the time that we can live doing the things that we want to do and the things that we enjoy doing that really give us that quality of life. This is national data, but actually if you have a look at North Eastern Yorkshire data, the most recent data for the North Eastern Yorkshire shows on average an 81.7 year life expectancy and a 52.3 year healthy life expectancy, which is dropping, which is a larger gap than England, as you can see. So nearly 30 years in poor health. We have higher rates of physical, mental, chronic illnesses, higher rates of suicide, higher rates of child poverty, higher rates of alcohol use, of smoking, and lower rates of physical activity. And so it can be really challenging up against that at a kind of, as Rani has said again, at a national societal level as to what we can do in practice. But it's always helpful just to visualize some of that. And I brought this up last time when we looked at obesity, because the factors affecting health are more complex than we think. And the bit at the bottom, the healthcare, affects about 20% of somebody's health outcomes. The other 80% are things that are around them. So again, that can feel a little bit overwhelming of what can we do, but actually there are some other things that we can potentially do to support some of the above. But just to go into the socioeconomic factors, for example, and how that might affect you, last time we talked about active travel, how easy it was to cycle around, how easy it was to get to our workplace by bike, how easy it was to lock up our bike. Did we know that our bike was still going to be there when we came back to it, having been locked up? Do we know that the routes are easy? But other examples might be around nutritious food and access to that. I'll come on to that in personal lives later, but again, thinking about your workplace and what the offer is. Do they offer nutritious food? Is it easy to access? Is it cheap to access? What is available to you? So our choices might not be as easy as we think, which applies to us, applies to our environments, and applies to the people who come to us for healthcare. So Rani referred to the social determinants of health. Many of you will be aware of this. If you haven't ever heard Sir Michael Marmot speak or read his work, there are links at the end to it. Highly recommend you to do so because he is absolutely passionate about this. And the things that are around us, which Rani mentioned there in the red and in the orange, are living and working conditions. And I've just given you some examples of those as well. But how our working conditions can affect our ability to access healthcare. So, for example, if we're working 3 different jobs, all on 0-hour contracts, and we don't know whether we're going to be working tomorrow yet or not, how do we book an appointment? How do we know that we can book an appointment? Or if we have a hospital appointment, for example, that might be far away from us, how do we manage to access that? And even things like physical or emotional stress in a job, access to food, as we've talked about, can really affect our health. So while that's not one of the protected characteristics, it might mean that we've got additional needs that we as healthcare professionals need to understand and accommodate for in the advice that we give. So night shift workers and long distance lorry drivers who might have additional health checks, for example, but also being aware of their particular needs in terms of being able to access our services. And this is a slightly newer concept you might have heard of called the commercial determinants of health. So this is thinking about the private sector and how that influences us. And you can see in the middle, you've got the green social determinants of health that are there. But beyond that, into the blue sections are the commercial determinants of health created by the private entities that actually loom very large in the world around us. And that's everything from innovation, supply chains, the things that sit behind around our so-called choices, lobbying, advertising, that all plays into our ability to make choices, and how the choices that we think we have are affected by the corporate bodies. Our governments are potentially, as Rani referred to, playing catch up on regulation and policy. And there are some book choices that you can have a look at to demonstrate some of this if you want to read more. Henry Dimbleby and Chris Van Tullochen have written extensively about it, so do have a look at some of their books. But increasingly, it includes our digital as well as our physical environment, where we spend a lot of time, the algorithms, the advertising. I'll show you in a minute as to what that might look like. And some of the work that goes on behind the scenes in private corporations, which of course interacts with us and our environment. And the Lancet have a really good piece, which this is taken from. And again, if you want to read more, do have a look at the Lancet and their series on commercial determinants of health. But actually, first thing I'm going to say is never, ever, ever type GLP-1 into TikTok, because your algorithm will be taken over forever. So this is from last time in our obesity webinar, when we had a look at how to find reliable health information online. Our target market now, particularly for obesity, you're talking younger people, and they are looking for information on TikTok. It is the fastest growing search engine that's used by the under 40s, by millennials, and actually that's where they're looking. Not necessarily Google, not necessarily bringing up the NHS website as we would hope, which it does, which is fantastic, but actually not bringing up any reliable health information at all. And it's not long until you get to people selling dodgy things and giving dodgy advice. So it just is really being aware that our choices that we make and our the people that we come to us have real risks from using that non-verified advice, non-verified support routes, counterfeit products. Even with legitimate providers, some are better than others, and cheapest is not always the best. So there is an awful lot that's shaping people's health decisions outside of the world that we inhabit. And another example of that is food deserts. Many of you might have heard of these. So this, we've talked earlier about the link between obesity and deprivation, and we've talked about the social factors, the commercial factors, and some of that is places in our country where ultra-processed foods, those high in fat, sugar and salt, are readily available, but it's really, really hard to find whole foods that have essential nutrients such as lean protein, fruit and vegetables. So that could be your corner shop, as opposed to having a supermarket or a greengrocer's. That could be takeaways, fast food outlets. You always think of it as an urban area, but actually in remote rural areas, such as small hamlets in the moors and mountains, we do find that as well, that it can be really hard for people with declining mobility to be able to get out and shop in the way that they would like to. So you've got higher prices, you've got limited choice, you've not got the nutrition, and that's before you even start to think about having the confidence, the time and the equipment to be able to cook well with the ingredients that we've got. And in a 2018 study, over 1 million people lived in such an area in the UK. But there is hope. So if you work in general practice or a primary care network, then hopefully you will have social prescribing link workers at your fingertips. If you work in a secondary care setting, then potentially you will have them. They might just be a little bit further removed from you, but they will be able to link in with local organisations, everything from benefits support, community gardens for growing food, cooking courses, food pantries which sell on leftover food for very low prices to reduce waste and can help unlock further support. So really this is one of the really important things on a local level. I can't tell you who they are, but they are out there. They are gems, and please go out and find them so that you can signpost people to them. I'm just going to have a brief look back at some of the frameworks and resources that we've used in some of the previous webinars. And we've looked at a number of frameworks to help us structure discussions with people using a health coaching approach, and to support and to signpost them in the right way depending on the scenario. And that framework, that professional curiosity, those questions help us understand the levels of health literacy and the resources that are available to them. Resources could be transport, it could be money, it could be time, lots of different ways, to understand and to support them. So we've looked at brief interventions, shared decision making, supported self-management and the change cycle. So we'll just have a look at them again in an inequalities eye, and reminding ourselves of Lisa from when we looked at lifestyle risk factors, and she had a wish to exercise more. She'd come to see you, her cholesterol was a little bit high, and you had an opportunity there to discuss her heart health. So as well as diving straight in with the statin conversation, you had a little window for a brief intervention on lifestyle to help her on her way. And using that brief intervention framework, you were just eliciting where she was at to understand her existing level of understanding so that you could pitch it right. Using the professional curiosity, you moved on to ask some more questions to understand whether she has the knowledge, whether she knows where to look for information, and whether she's actually motivated to change at this point, and if she is, whether she knows the steps that she can take to change, and whether she has the resources to put all of that into practice. So you'll see here from the conversation that we had on that webinar that we're asking the questions and Lisa is providing the answers, and that feels very different to a lot of the interactions that we might have, but in about 2 sentences more than usual, we've got time to make sure that we can create a tailored plan for her through the answers that she's given. So just using that can support you alongside a range, clicked on a bit too fast, alongside a range of resources that we can use to tailor that conversation. So we've got the key risk 3 on the top left, which you can have a look at somebody's heart risk. And on the bottom right, we've got some actually very similar information from Heart UK. So you can use these depending on somebody's level of health literacy. Top left, you might be looking at someone who's got a little bit more thinking about, well, what happens if I do this? What happens if I do that? Oh, this is quite good. Oh, that sounds fantastic. Bottom right, actually somebody who perhaps has a lower level of health literacy, and perhaps actually being able to point and say, tell me a little bit more about that, can help you decide, what am I going to pursue? What am I not going to pursue? And talking through the link from cardiovascular events to heart health, the factors that affect it, atherosclerosis, lipids, statins, lifestyle, and helping them to join the dots to make an informed decision. So there's some great information on Heart UK there. British Heart Foundation also have leaflets in other languages for download or sending to people. So especially where someone has English which is not as their first language, then they might be able to support that. Sorry, I'm not sure why these are flicking through quite so quickly. But just as the risk factors are individual, so is accessing that expert advice. So when we're coming to say, would you like me to signpost you? It's just a little bit of understanding what's available to you. Some things are digital, so they'll be available to you nationally. Some things might be local. It might be an individual. So your health and wellbeing coaches in your area, for example, knowing who they are through your council or your care coordinator. And on the right-hand side, this is from Maryport, which is an underserved community in Cumbria where I live. They have a fantastic little gem of a service called Fit for Life, which is partly sort of not-for-profit and also partly NHS funded, so has some fantastic schemes that can support people, everything from cardiac rehab to older people's activity. So there are digital resources again for people who prefer those. So again, there's some information from Heart UK there, and from This Girl Can, and for people with chronic conditions, there's also We Are Undefeatable. So it's just having that little toolkit of resources when you're coming in to talk to people and be able to offer them the options. And it wouldn't be a webinar with me if I didn't mention Morning Live is back, and they have a movement section every morning, including standing and seating exercises that anybody can have a go at. Because if you don't give them the information, they're going to go on TikTok and type it in. This was from our kidney disease webinar. And again, there's some really good stuff on there. So we've got Dr. Amir Khan, who is fantastic and engaging on there, but it doesn't take you too long to find somebody who's going to sell you dodgy herbs that are supposedly good for your kidneys. I'm fairly sure they're not. So just making sure that we are signposting people in the right way. There are alternatives. So the NHS website, which is written in really simple language, that's really helpful for people who like to read. Again, that can be printed for people who are not digitally literate, or sent a link to for those who prefer that. And then this was the Kidney Care UK website. Highly recommend you have a look at their resources. They've got videos, which is fantastic. So particularly, again, if somebody isn't able to read or doesn't like to read and prefers to watch a video, and they've got some infographics that helps you join the dots together. So some great examples there that you can have a go at. And then the practicalities of managing medicine. So we looked at this way back in our cardiovascular disease, and actually the choice to take medicines or not for somebody is quite often not clinical, but it's practical. So we looked at the issues that Jamal faced with his statins, and we might make assumptions for Lisa as well about practicality. So your daily routine, how does it fit in? How do you remember to take it, to actually take it? How do we remember that? Where do we keep it? Particularly for someone who's not had medicines before. The ordering and collection, making it as easy as possible. So you might be signposting to electronic repeat dispensing or the NHS app. Maybe someone has additional needs and actually needs support from a carer or partner who needs to be part of that conversation with them. And reasonable adjustments. So there's a new flag on the system. You might have heard the new scheme that comes through to the National Care Records Service and all of our clinical systems, that you can put a flag on the system to make it visible to say this person needs additional support. So again, if they need support from a carer or partner, if they need things that are in video format, for example, if they have phone calls, if they prefer text messaging, then that information can be flagged up on there so that anyone involved in their healthcare can see it. For medicines as well, the responsibility of the dispenser around administration, so dexterity issues, for example, or vision, if they need large labels. Braille is on the medicines packets as well. For swallowing, it might be the dosage form, so that's the prescriber's responsibility. So, if they're having difficulty swallowing, is it just tablets? Do they need speech and language therapy support with eating and drinking, for example? You might be having a think about the options there. Appointments as well, we've covered with transportation. How many do they need? Where are they? Are they required or optional? Are there options for remote? Does somebody have access to digital services? Do they have access to transport to be able to get there? Can they take the time off work to get there, to be able to come in? So looking for a medication that has less monitoring might actually be really important to somebody to make it manageable. And carers and partners we've talked about, you know, Lisa's here is fictional, but actually we'll have her in our mind's eye and probably fairly sure she'll be pretty independent. But is there someone that we might need to think about? So for example, would she need help with transport if she wanted to access exercise opportunities? And just as a reminder at the end, are your medicines working for you? Some of that is clinical, but some of it is also these practical things. Do they fit into the lifestyle that you have? And are they practically going to be able to take? So I'm going to finish up just with a few real life examples for practice. Very different types of health inequality, but all with very real world examples. So I'll just ask you to read Alan here and just start formulating in your mind what the scenario might be. So he's a long distance truck driver. He's away most nights. He sits down all day. He has access to very little kitchen equipment, but he wants to improve his health through diet and exercise. And how can you help him? So I'm just going to leave that up for a minute for you to digest and start thinking about Alan, and then we'll just move on for you to be able to type that in. Again, this is not a protected characteristic, so it's not one of the things that we might think about. Now, we might be coming to you for the HGV sign off, but that might be all he's coming to you for. But actually this is something that Alan might find difficult to access. So how can you help Alan, the truck driver? I'm just going to click on to the next slide, and you can now join the Slido and start typing in. It is anonymous, so don't worry, nobody's going to see what you've typed, but just a few thoughts and words. And let's share our expertise with each other. If you've worked extensively with people in this scenario, it'd be great to hear from you. Some good thought going into these answers. I think they're going to be quite detailed when they pop through. Don't worry if you just want to put a couple of words on with an idea, that's fine as well. There we are. So we've started to see them coming through. So preparing food that he can reheat, regular rest stops, encouraging getting out and walking. NHS website, good. Take a walk at every rest stop, changing position, yeah. Exercises that are practical, so body weight exercises, for example. Pre-preparing food rather than buying ready meals, that's great. And we'll just give that another 30 seconds for people to put in. Seated exercises. Yep, can he walk to work? So can he get that active travel in his commute to go and pick his truck up? So some really good practical ideas there. Are there healthy foods at some of the truck stops? Yeah, it's got a choice. And regular breaks. Yeah, absolutely getting that in. So let's move on. It will stay open if people want to put things in afterwards, and I will share the results of this back afterwards as well. So this is example 2. So this is Alma. She's autistic and struggles to use the telephone and being in busy spaces. And following her fight to get her autism diagnosis, she's worried about not being believed about any health problems that she has. Her practice has invited her in for a physical health check to help her. So what would help Alma book and attend? And again, I will just leave that up for a minute for you, just so that you can digest it. Just start getting a few ideas about how we can help Alma book and attend an appointment. What can we do? What adjustments can we make in our care? And autism is a recognised disability, so we are into protected characteristic territory with this one. And legally, we do have to make reasonable adjustments for Alma's care. So let's click over and start thinking about it. So how do we help Alma access her health check? There we are, that started coming through, another very popular one. Yeah, ask her what would help her. That can be good. Quiet visit times, yeah, less busy place. So maybe start or end of the day might be really good. Online booking options, fantastic, yeah. Flexibility, excellent. Some great ideas on this one. You guys have, many of you obviously come up against these. Yeah, so visiting in person and not having telephone appointments, which she might find difficult. I really like that one. So ask her if there's anyone that she wants to bring with her, and reassurance, that compassion, just to say, actually, yeah, we're here for you. Excellent. The reasonable adjustments flag, longer, giving her more time, inviting her to bring questions with her and offering a write-up of the discussion afterwards, so that she doesn't have to remember. Yeah, really like that top one as well. So a recognition that people might want to bring comfort items with them. So some people use little stim devices, for example. Brilliant. Okay, thank you. So we've got time for one more, I think, before we wrap up. This is Fatima. She's 85 and she lives alone. So she struggles with her eyesight, her memory and dexterity are fine. She doesn't have her own transport. She relies on her neighbours. She's on 8 different medicines and thinks they're making her feel a bit fuzzy. So what are the issues for Fatima around managing her medicines? Quite a bit there to digest for Fatima. So she's 85, by herself, eyesight problems, doesn't have transport, and her medicines are making her fuzzy. So there's a lot going on for Fatima. How can we help her? I will just finish up by putting in a few examples. Here we are. Good. So structured medication review from the pharmacist. Yep. Larger writing. Yeah. We could offer her a sight test. Yeah? So has she had a sight test? Anticholinergic burden. Fantastic. Structured medication review. Yeah. I'm just going to say on the dosette boxes that they can be helpful in some scenarios, but it's the responsibility of the dispenser to have a look at that, and the medication review should always come first to see are the medicines working, and then it's hand over to the dispenser to see what she actually needs, because they can sometimes do more trouble than good. Frailty review as well. Oh, that's good. So thinking about her holistically. Is there a delivery service that's available? Does she need a social prescriber because she might be lonely as well? So that is really helpful. Some great ideas coming through here. Absolutely love them. Age UK, yep, is the third sector support locally who can spend some time with her. Can her do her neighbours want to be her support? Love that top one about the hydration and nutrition. So she might not be feeling very well. Does she need extra support above that, such as district nursing? That's grand, thank you. I'm not going to go through the last example just because of time, but just we've got a Romany gypsy with a reading age of 5. If we're using chloramphenicol for them for an eye infection, we need to consider they're not going to be able to see a GP in one place regularly, so they're probably going to be more reliant on pharmacy care. We may have to do things like annotate with numbers in terms of the numbers of times of day that someone is taking something. And if they don't have access to a fridge, then we can't give refrigerated items. So we would have to use ointment rather than drops. So we've been through quite a few examples there today. We've had a look at the context, we've had a look at the frameworks, and we've had a look at some examples of that. Thank you very much for listening. All of the resources are on the end, and you will get the slides afterwards. Thank you.
Thank you, Helena. That's excellent. There's one question in the chat, and it's about hospital stays. And we all know that hospital food is not always quite what our patients might want at the time, and it varies between individuals, obviously. But does a stays in hospital affect adherence to advice about healthy eating in both directions?
Right. I've not worked in a hospital, so I can't really comment on that aspect, but I think we are all aware of deconditioning in hospital. So when somebody has a stay for more than a few days and has many things done around them, you can end up, for example, with what's called pajama paralysis, where somebody spends a lot of time in bed with things done for them, and that can really affect their ability to when they come out. Others may know more about that than me.
Okay.
Yeah, I mean, I'm speaking probably as a patient who stayed in hospital for a whole year. I think that the options available might challenge what you're used to, I guess, is another thing. Another discussion are the dietary provisions when we are admitted to hospital for long term. It is challenging. It is challenging. So there is an impact. Depends where you're admitted, but generally speaking, there are going to be changes to what you're used to versus to what you have to kind of live with when you are offered what you're offered. Maybe something for us to do as healthcare professionals in these provisions, but some things which are reality.
Yeah, I think it's very difficult, isn't it? Because it isn't
Yes.
just what you used to, but also your underlying condition as to why you're in hospital in the first place may actually
That's correct.
be impacting. And perhaps one of the best things is to minimise hospital stays, and that will reduce both those things. Just to reiterate to people, the slides and presentation will be shared afterwards. So that just leaves me to say thank you very much to both our speakers. Thank you to all of you. There's a slide just saying that we will be circulating the survey, and do please complete that. And there's a prize draw for a £25 Amazon voucher for further encouragement. Thank you both, and thank you to all of you. Goodbye.